We're back again, and I'm still going to try and keep the shorter format, and I'm going to be trying to talk at you rather than reading off the studies or share my screen with the studies. So what I'm going to do is I'm going to go to each one of my tabs. We're just going to very briefly discuss what am I talking about, what did the study say, and is it relevant? Do I have any short thoughts on it? Okay, so that's going to be the goal with this series going forward. So if you have any preferences on how we operate, let me know. So the first one on the docket is going to be head posture, and does it correlate with head and neck pain? No, it does not actually cause neck pain. So an excessive forward head posture does not in and of itself cause excessive neck pain. What does seem to correlate on why those two things go together, why if you have forward head posture, do you seem to have increased neck pain, isn't because the posture itself, it's usually twofold. One is if it is an excessively sustained posture, like anything else. I could have perfect posture. Give it 20 minutes, I will be in pain. I could have garbage posture. Give it long enough, I will develop pain. It is sustained postures because a lack of movement is really what gets people. That ties into the second point, and that is these habits where people sustain these positions for long periods of time typically do not also have good overall health habits. These people typically will be up late dealing with insomnia, being on their phones until 1 or 2 a.m., and not seeking additional physical activity nor taking care of themselves. So like some other things, this is an association that is not a cause and effect. It is a correlation because of the additional habits that these people embody, typically. And we're talking broad strokes, okay? So the actual posture isn't causing the neck pain. It's sustained positions and other health habits typically associated with modern culture that seems to be playing into why people have this pain. Next study, assessing your shin muscles when it comes to chronic ankle instability. Specifically, we're looking at muscles on the outside of your shin. Some people learn them as peroneus muscles. Other people learn them as the fibularis muscle. I happen to like fibularis just because if you know anatomy, you have the fibula, fibularis. With the fibula, it's easy to remember where it's at. So what they wanted to take a look at is when you're assessing it in people with chronic ankle instability, is there a, again, correlation between that muscle and chronic ankle instability, as well as ways we should be assessing it. And the two answers that it came up with in this study was first, there does seem to be a smaller cross-sectional area in people with chronic ankle instability and their fibularis musculature. The second thing they noted is that this was emphasized when they were standing like I am right now or balancing on one leg. That is when they really noticed during ultrasound the reduced cross-sectional area that may either explain their continued ankle instability or why they have other associated lower limb disabilities with it. When you were just lying down, it was not as easy to parse out if they had a reduced fibularis muscle cross-sectional area. So when we are looking at it, and I don't have an ultrasound device, so when I say look, I mean very much from a functional standpoint, chronic ankle instability needs to have an active component when you're assessing it. Much like most of what I treat, that's kind of a no duh moment. You should be an active individual. I'm not saying you have to be a gym goer 8 hours out of the day, but you do need to be active, which means a lot of our assessments, treatments, interventions need to happen with activity. That should be a goal of ours clinically and for you from an outcome standpoint. When you work with us, we need to make sure that we are pursuing the goal of activity, being active. Okay. Now, next, hamstring strength and hip mobility. Is it associated with pain and disability in the low back? Short answer, yes. I like this study for a couple reasons, actually. The first one is a personal bias on the tool that they used. They used something called the NORD board. It's a very specific dynamometer or muscle strength assessment tool. And the NORD board is from the company that I love using. It's from Vald. I have their handheld dynamometer. I have their force plates. It's been a huge boon to me clinically, and I love seeing it kind of pop across my desk in other ways. And the fact that they're doing research and that the entire setup to assess this question was using their tech. It's just a personal thing. I love seeing it. But let's continue on to what they said. Um, Hamstring strength and hip mobility is associated with low back pain. This isn't, we don't really need to think too deep into the why, because there's so many possible avenues we could go. What we really need to do is that the body is, to a degree, interlinked. And what I don't mean is that, you know, my pinky is technically connected to my toe, but the level of effect my pinky has on my toes, very minimal. They're only linked insofar as they're a part of me, attached to me. What I more mean is that this link, these body parts from a mechanical standpoint, how I move, squat, sit, stand, walk, they are so close and have to work so closely together that it really doesn't take much clinical breakdown to see why this makes sense. Why, if we have low back pain, it should be my job to assess as many of the initial avenues as possible. This being, oh, you have low back pain, does not mean I'm only going to look at your back. No, low back pain means I need to look at your whole picture, get your history, make sure more than anything else what this is not. So red flags, big bad, crazy stuff that I need to refer out to. So long as it's not that, I have almost carte blanche to then treat you as a whole person and figure out what is the lowest hanging fruit that we can attack first. So in the case of low back pain, it may be something in your low back, like, you have terrible low back endurance, or maybe you eat and drink like a campground raccoon, so we need to address a lifestyle factor. Or maybe in the case of this study, you have terrible, terrible hip to low back, hamstring to low back relationships and mechanics. If we put this and just leave this online, people are going to be on two sides of the camp. They're going to attack me for two reasons. One, how dare you say that this can be a factor? People are only, whole ecosystems, that you can't parse a single cause out there. And on the flip side, you've got the people that are like, how dare you consider anything outside of the low back when it comes to back pain? Please understand this format I'm trying to keep succinct. So when it comes to me saying that it really comes down to the relationship and we're going after the lowest hanging fruit, if I have somebody that has egregious mechanics of the hips, terrible hamstring strength, that may be something that I want to explore first because I can get the biggest bang for my buck in the shortest time, addressing the largest deficit. That's really all it comes down to. If we figured out that your low back pain has either a mechanical or anatomical component, which happens often in my office simply because I'm trying to get and keep people active, and a lot of my interventions are going to be exercise or movement based, typically means that I will find some sort of a deficit that we can address, and hitting these lowest hanging fruits first often give us the biggest first step, so that the rest of what we do and build from is A, more efficient, B, we've already built that trust because we're on the right progress. We've essentially built momentum is what I'm trying to say. But I feel like I'm starting to rant, and that's not what I want to do with this. So let's actually go back. I'll read you the key parts of the study and we'll see if I have anything else to say on my soapbox. So what they did using the snoreboard is they took almost 130 people, 67 with low back pain, 62 with not, ages 18 to 35. They looked at strength and then they tied it with asking them questions on outcome assessment tools for pain, disability, etc. So these patients filled these things out, and they wanted to see, based on their answers and their scores, was there a connection? And what they found was hamstring strength and hip mobility are key correlates of low back pain severity. Cutoff values were determined for different metrics, and this should be viewed again as researchers and these initial questions. They basically say, this in sample discrimination should be interpreted as a hypothesis generating outcome rather than a diagnostic outcome. We get that. What could be happening and what likely happens when we see these correlations happen? By not having sufficient capacity in directly linked and interlinked muscles and bits of your anatomy, your body has less options to perform your required tasks. Put another way, if my job is to pick 100-pound bags of concrete or shingles or something off the ground, and my body, when it assesses what I'm capable of in any given moment, subconsciously knows that my hamstrings are comparatively weak for the task, it will consistently recruit other muscles to do the job at hand because you have a job to do. This isn't a discussion on perfect lifting mechanics, posture, etc. What this is saying is if I have another person doing the same task who has a strong back, strong mobile hips, strong hamstrings, your body has more resources to pull from to do that job, which means that there's less likelihood that it needs to put on the brakes in any form or fashion. The easiest way that the body puts on brakes, especially during these tasks, is to initiate the pain cycle. Because what do we do? What is our instinct to do when we are in pain? It's to stop the thing in pain. Pain is not necessarily a pleasurable experience. At least it shouldn't be. We have words for people that enjoy that. However, the person that doesn't have the movement options available because they lack capacity, the body will initiate the pain brake. In somebody who has additional options available to them, they can cash in and pull from that bank, from their movement health account, that withdrawal, to do the job without overdrafting and forcing the brain, the bank, the branch to say, you can't pull from this anymore. We're freezing the account. You now have pain. Don't pull from it until it's refunded or restored. That's essentially the current thought process on why we see these correlates, why they're important, and why they're important to address. Again, you watch social media enough, it'll confuse the bejesus out of you. I understand why. It does for me a lot of the times. I don't understand why people are arguing on certain things. I also don't understand why people aren't arguing on others, but such is life. I'm going to move on before I get onto a new soapbox. The efficacy of kinesiology tape for rotator cuff injuries, a meta-analysis. Long story short on this one, it did find that a lot of the randomized controlled trials and research articles that it looked through to generate this review found that KT tape had good effects on mitigating pain with rotator cuff injuries. It said proceed and interpret these with caution because there's bias, there's other risk factors at play within these studies. Personally, clinically, going through school when I was using more KT tape, I saw what these people were saying as far as it does improve pain function and certain disabilities as long as the person is diagnosed correctly, educated correctly, given other movement things to do. The tape shouldn't be viewed as a fix-it-all or a band-aid. It's part of a whole treatment approach. So as long as we are understanding that, it's great. I will personally say I have a huge bias towards dynamic tape. It has been a game changer in a lot of different conditions because rather than just putting the tape on and having the proposed hypothetical skin effect where the tape being on the skin is, I'm going to use the word irritating the tissue, but not in a bad way. It's a constant sensory input that can affect somebody's interpretation of pain, as well as there's the proposed skin lifting mechanism where you're getting additional fluid through an area that is injured that may help with recovery. Again, that's a proposed hypothetical mechanism. I don't know if it's true or not. Going back to my bias with dynamic tape, this for me has been, if I was to summarize it, I can essentially tape on an accessory muscle, a flexible or mobile brace, depending on how we do it. Um, and this tape allows for natural movements with less force going through an injured area, which has improved recovery and compliance so much further than I found with KT tape that I don't think I've used KT tape for its intended purposes in, gosh, I think most of my actual professional clinical career. So again, personal bias, KT tape, the studies abound. It seems to be A-okay as long as it's used right. I'm using stuff that I feel is way, way better for similar but different reasons. But it's a clinical tool that I thoroughly enjoy using. I personally find has great benefits. And if you're debating, do I need a brace for this? Do I need to do X, Y, and Z? Should I keep moving? We can definitely talk about maybe taping you up and giving you a temporary reduction in how much force you have to put through a sensitive, painful, whatever it is, area and keep you moving. So I love tape. It's great in the right circumstances, and I feel like I'm using the best stuff on the market. Next up, this one's short. I don't really have anything to say about it other than what I researched. Central obesity rather than BMI is actually associated with chronic pain. So other studies have talked about chronic pain is associated with BMI. However, if we parse that out, BMI isn't great on a one-on-one basis. If we're talking mass population where you don't have the time or ability to get central obesity ratings on everybody, just doing a height to weight ratio, it's one of those, it's good enough, which is why BMI is so prevalent. However, ever since I was a late middle schooler, no matter what my actual physique was, I'd always be either obese or morbidly obese on the BMI scales. Even right now, I'd be categorized as overweight, legitimately. Anybody who has any average or above average musculature with below USA average levels of body fat is going to be typically mislabeled or miscategorized on BMI, which is why one-on-one, we don't use it. We use different metrics for central obesity. We use different ways to actually measure the person in front of us to give them a better clinical indication of their health. So this study basically wanted to say that further. If we're looking at a population standpoint, and if we're talking about chronic pain, it's not actually BMI that should be considered the correlate with it. It should be central obesity, so that abdominal obesity, visceral obesity, that's the thing associated with chronic pain. And again, for reasons that are typically lifestyle oriented with people that have this central adiposity. All right, last three studies. Spinal manipulative therapy for adults with chronic low back pain. This was a Cochrane review, so very much like a systematic review. It's a consensus of all of the studies out there to be able to make a more determined statement about the thing being studied. So with spinal manipulative therapy, what did they say when they compared it to sham, when they compared it to no treatment, and when they compared it to other therapeutic interventions for people with chronic low back pain? Pretty much, if you've watched my other studies, it says what we've already discussed. So if we compare spinal manipulative therapy to no treatment in people with chronic low back pain, we have at least moderate effects or moderate improvements in pain, in low back pain, if we adjust them versus if we did not. Yeah, there's lots of studies that show that. If we compare adjustments to sham adjustments, there's less of effect. There's still some, but there's less of an effect. And this is where uh, contextual aspects of an appointment matter. Um, most of the shams are still putting a person. Sorry about that. My headphones turned off because I actually don't have anything going into them, but let's go back to it. Compared to sham, you're still putting your hands on somebody with sham, even if you're not actually going through with an adjustment. So there's still going to be background or placebo reasons on why people get better, which is why you don't see as big an effect between the two, which gives people some reason to say, aha, adjustments. There's so much of it is actually just placebo. There's not that many mechanistic things that improve back pain. One, that could be discussed, you know, true, false, how much does it play into it? But I think the bigger thing too comes to the fact of who cares. Even if manipulation, adjusting is entirely placebo, but I tell a patient that it is safe and I expect an improvement in their condition doing this, and I essentially discuss it with them in an ethical way where I'm not curing them. This isn't magic. This isn't anything mechanical that's going to put a bone back in place. I just tell them that I'm going to try and get the area to move. And if I do it right and we don't put you through excessive pain, because it shouldn't hurt, you should get better. We are using placebo. So many treatments are actually placebo that people will admit or don't want to admit. And that's a big reason why they get better. But people seem to have a moral high ground on, I refuse to use. No, I will absolutely use placebo. You can't divorce placebo from so many things that we do, especially as clinicians, whether we're working remotely with our hands. There is almost no aspect of a patient encounter that doesn't have some level of placebo in it. You just can't do it. Surgery, they've studied it. A lot of what they have as far as levels of improvement from a pain standpoint, placebo. Manual therapy has tons of placebo. Patient communication, biopsychosocial interventions has a lot of placebo to it. I don't care. You're going to get better. So in this one, comparing legit adjustments to sham adjustments, legit adjustments were still a little better. People still got better on sham, attributed to placebo. Actual adjustments had that plus a little extra. And then when you compared it to other therapeutic interventions, they just categorized them broadly. It could be, instrument assisted, pin and stretch, hands-on work, massage, acupuncture, dry needling. The list goes on. Then the actual benefits above and beyond for spinal manipulative therapy kind of peter out. They basically said it's no better than any other therapy, which great. Means if everything else is the same, I get to really pick what intervention is going to be the best for the patient in front of me without having to rely on a specific intervention that the patient may or may not be on board with. Take like dry needling. Dry needling is the same in almost all metrics except for cervical spine pain, chronic cervical spine pain, except range of motion. So if the person wants range of motion, I can slightly edge out the discussion to dry needling. But if the range of motions are, no big deal and it's just pain, then I can be agnostic about, hey, we can do instrument assisted work with adjustments. That has some pretty good evidence. We could do dry needling with adjustments. Like it lets us be flexible to the person in front of us to really pick out what they're comfortable with, what we're comfortable with, and just make sure that the appointment in and of itself is customized to the patient in front of us. So this to me just is a great benefit to the argument of manipulation. and other therapeutic interventions. Last two. Chronic pain prevalence trends in urban, suburban, and rural areas among adults ages 55 and up from 1998 to 2022. Really, 3 bullet points explain this entire study. Pain has consistently been higher in rural areas, but has increased across all areas within the time frame measured. Since 2010, suburban areas have seen a particularly sharp rise, now nearing their rural level counterparts, and small but important differences in pain trends are noted, distributed by age, sex, race, ethnicity, and census regions. So chronic pain is just going up despite our best efforts. This is why we do what we do, how we do. We are trying to redirect the river, the trend, so to speak, with our treatment model, our treatment approach, where we're at clinically. We're at a gym now. We're trying to be as active and participatory in our patients' typical lifestyle activities. So rather than taking a separate trip to my office, you now just go to the gym like you would have done anyway. You see me. We're going to get to work. We're going to figure out lifestyle factors, diet, nutrition, sleep, stress. We're going to figure out, physical endeavors that may help, whether it's a passive manual therapy side just to calm things down in the moment, versus now we're going to build you up. We've got the data to back it. Like, hey, the lowest hanging fruit that we've triaged is XYZ. Let's hit it hard, hit it fast, get you going so that we can interrupt and start redirecting to the best of our ability this huge trend towards chronic pain. Last study. Speaking of associations, body composition characteristics and chronic low back pain in high school baseball players. This is one, going back to the central obesity versus BMI debate. They, for these high school athletes, wanted to figure out when they assess their body fat percentages, who had the higher risk and severity of chronic low back pain. And it tied with that last study. The people that had more body fat percentages for their size, so they were higher in the central adiposity, they had higher levels of endogenous fat stored on them, they had a greater incidence of chronic low back pain. They basically sum it up as this, and this might be a perfect little summary before I end this video. Elevated body fat percentages and elevated pain intensity in early high school years were associated with the development of chronic low back pain among high school baseball players. Regular monitoring of body composition and early intervention based on pain levels may be effective to prevent chronic low back pain in this subgroup, thereby supporting better long-term athletic performance and health outcomes. That basically ties together the last study I talked about with chronic pain prevalence, central obesity and adiposity, as well as measuring people and assessing them while they're active with the chronic ankle instability. So, what better way to end it than just say there's so many things going on in life. All of these things are multifactorial, and we love what we do because we're able to affect so many different things in so many different ways for so many different people. Even if what we do looks like it's just personal training or physical therapy from an outside perspective, we're trying to tackle all of these things within each one of our appointments, within each one of our patients, and we look forward to helping you on the other side, whether it's just with these educational series or if you want to actually go through with an appointment and kind of cut things off before they get through the pass, as it were. But I'm going to come up with random weird metaphors if I keep going because I'm starting to ramble. So until next week.